it seems kind of, especially when we're dealing with large issues of structural violence. But what we found through our research and practice is that everybody can make a difference, and this work is doable. So we'll point you to some additional curriculum as well as resources that we've developed to support the work. We always like to start by acknowledging that while this work is not particularly complicated in the sense of reorienting yourself to being trauma and violence informed, it's not easy. And it's not easy because it forces us to be a little bit disrupted. But we have to recognize that, especially at this point in a 3+ year long pandemic, where many issues of social injustice have come to the fore, and we've seen some of the inequities in society and groups that have disproportionately been affected by COVID, often the groups that were disproportionately affected by inequities prior to COVID, we're all very tired. So we do like to acknowledge that we're not alone in this feeling of exhaustion, that the work that we do to support people, to support older adults who might be experiencing or at risk of experiencing violence, or others who are experiencing structural interpersonal violence, is hard work. It takes emotional labor. And when we can't do the work in the ways that align with our values, especially in systems that potentially are forcing us to work in ways counter to those professional standards and also personal morals and values, we can experience this as moral distress. And it's not easy to discuss this sometimes because we have to implicate ourselves in these processes. So I would urge you to protect yourself as you listen, take breaks as needed. But let's get a little bit disrupted because, if nothing changes, nothing changes. And I do think we need to prompt a little bit of that good disruption so that we can start having conversations to promote change. So let's talk about being trauma informed. So what is trauma? Trauma is both the experience of, and importantly, the response to a negative event or events that threaten a person's safety, life, or integrity. Basically, these are events that can overwhelm somebody's ability to cope. And not everyone responds to trauma in the same way, and not every event or series of events will be experienced as traumatic by different people. So it's important to recognize that people will have different responses to traumatic events and traumatic experiences. But one point is this is more than just everyday stress. And when we're in the realm of what we call post-traumatic stress, post-traumatic stress disorders, and that sort of thing, this is more than just stress, but it's anticipatable. And I think that's an important point. So I've sort of highlighted some words here and there through the presentation as key takeaways. And we've done many different workshops and other forms of education around TBIC and actually evaluated the impact of that teaching and learning. And we see where people sort of have these aha moments. And this notion of being able to predict or anticipate that some people will have, the types of responses that you might see in your practice is an important key point. So basically, we are designed to respond to significant forms of threats in ways that protect ourselves. And another important point is that traumatic stress can be both acute, so resulting from a single event that can be quite horrific, accidents, natural disasters, and so on, and or it can be chronic and complex from repeated experiences, and I'll talk about that in a minute. And responses can include a range of things, and they'll look very different in your practice, and I think that's the important point here. And even within the same individual, a response might look different from one encounter to another, and certainly different people will express their responses in different ways. So it can be, the 4 F's, the fight, flight, freeze, or fawn. So people can become very defensive, agitated, even angry. They can withdraw or become disassociative. So you're not even sure if they're actually engaging with you. So this is quite a range of responses. And I think one of the points that we're trying to emphasize is that when you're interacting with people who have experienced these forms of trauma and the resulting traumatic stress, you might see a range of different responses in your practice. And you need to sort of be aware of what that looks like. And then through a TBIC lens, start to think about the sorts of ways that you can respond that are supportive and safe for people. So again, emphasizing that what trauma looks like will differ between different people, between different groups, and is always culturally bound as well. So there are parameters in which, our own experiences in our communities will make some responses more or less acceptable. So that it's important to also to keep that lens about where we come from and what we bring. Trauma is extremely common. So this is another very important point. And we talk about TBIC as a universal approach. And that's because really, when we look at this map, and Canada wasn't involved in the global mental health survey that's sort of emphasized here, but a similar study in Canada would put us in the red zone. So when you look at Canada here, we would be red like the US, like Australia and so on. And that's in the range of over 3/4 of the population having experienced one or more forms of trauma that would meet the threshold of post-traumatic stress. So if you yourself have not experienced directly these forms of trauma, you certainly know people within your immediate circle who have, and you've experienced potentially that trauma vicariously through their experiences of that. So it is so pervasive that we really promote taking a universal approach to trauma and violence-informed care. And some examples of traumatic experiences are presented here. I won't read the entire list, but to emphasize that we group them loosely in 3 groups, recognizing that there's interrelationship among the 3 categories. So interpersonal forms of trauma, and I've highlighted and bolded a few of those here. IPV, children's experiences of IPV and their own direct experiences of child abuse and neglect, and abuse of older adults are interpersonal forms of violence. And then we have situational forms of trauma such as war, genocide, etc., extreme poverty, refugee experiences, and so on that are represented in pink. And then acknowledging the collective and historical and ongoing forms of trauma, such as colonialism and legislation that still exists that perpetuates colonial practices, residential schools, and so on. And I would also add COVID-19 as a collective traumatic experience that we're all still living through. So a key point on this slide is that these 3 forms of trauma are often interrelated. So if I use the example of a newcomer to Canada, if that person has left a situation of war or genocide and then had to be relocated to a refugee camp, the fact that they've been in a refugee camp, first of all, they've experienced the war and genocide and that violence in their home country. But then a refugee camp experience, which can often be years long, is itself very traumatizing. And in fact, that experience is more likely to subject, for example, women to sexual violence. So that you see sort of that situational trauma now being related to interpersonal violence and interpersonal trauma. And in the context of a genocide, that's a collective trauma. As they transition to a new home country, there might be experiences of poverty, lack of access to safe housing, and so on. So now you're starting to see that experience, that initial experience of trauma being played out and following people through a process of migration and transition to a new home country. So you can start to see there's a level of complexity here where these forms of trauma intersect and interact. And an important point is that, as I mentioned before, these are not choices. The way that we respond to traumatic stress and the level of threat that's involved is a physiological response. So this involves hormones in the brain. I'm not a neuroscientist, so I certainly won't go through this in sort of scientific detail, but basically your higher order reasoning and functioning shut down to prioritize your physical safety. So you become what I guess is called brainstem driven. Where your first priority is to be safe. And that's where you can get into the, fight, flight, freeze, fawn response, something that is going to keep you safe and from being harmed in that moment. So it's not like we have control over this. When cortisol and other hormones and chemicals are released, our bodies take over. And we can all sort of, I think, empathize with that feeling of your heart rate going up and really sort of having trouble breathing and feeling that it's time to escape a situation because we're not safe. And these trauma responses, especially when traumas are severe and or chronic and complex, so ongoing experiences, can start to affect actually the way that we express our genes. So that's when you get into things like epigenetics. The earlier in life these things happen, the more likely they are to sensitize your ability to respond to later events. And essentially, the way I describe this is when you get in a state where you're experiencing repeated forms of trauma, And you can't go back to sort of a homeostatic or normal baseline level of those stress hormones. You're in that constant state of agitation, of hyperactivation. And that might make it difficult for you to, respond in ways other than fight, flight, freeze, or fawn when those experiences are reactivated through various experiences. So, as we get away from thinking about what's happening within the individual, we recognize that individuals are embedded in social systems, embedded in families, in communities, and in society. And those factors will also influence our ability to be protected from these more adverse trauma responses. So we look at things like social cohesion, the amount of violence in a neighborhood, as being either protective or putting people at increased risk. And what I would say at this point is we really need to look for those protective factors to support people being able to, and I'm going to use the term resilience, although I do have issues sometimes with the term resilience because we put too much responsibility on individuals to be resilient, but I'm going to say we're going to be structurally resilient. We're going to find ways to protect people and groups from the worst impacts of trauma on their lives. And I don't have time to show this video, but I'm certainly happy to share the slides. This is a nice video done by a colleague of mine at one of our research networks that sort of explains, especially when these traumas occur in childhood, how it impacts our brain, body, and behavior, and how these things are all interrelated. So we do know from a lot of research that trauma and violence are predictive of poor health. And this is the case in terms of chronic diseases, hypertension, type 2 diabetes, arthritis, musculoskeletal disorders, mental health issues, also sleep disorders. And again, when you're not sleeping well, everything can be affected, but certainly post-traumatic stress, depression, anxiety disorders, etc. And importantly, health behaviors. And this is where, especially when I'm speaking to healthcare audiences, but really to everyone, that we need that sort of shift from judging people for things like misuse of substances or smoking to trying to find some compassion in understanding that people are trying to find ways to cope. So I've highlighted two words on this slide: chronic pain and substance use. And I'm not going to go into a huge amount of detail, but I do want to show you this graphic. And this is in a forthcoming volume that we're about to publish. I'll tell you about a little bit later. But this, I know it's a complex diagram and I won't go into all the detail, but to understand that when we are suffering from physical pain, emotional pain, spiritual pain, we want to control or mitigate that suffering. And in some cases, that's through use of substances. But substances themselves are not all seen equally or treated equally. Some substances are highly stigmatized. Some routes of use of substances are stigmatized. For example, taking an opioid through a prescription pill is one thing. Taking an opioid through injecting drugs that are bought on the street is another thing. And each have levels of stigma and risk involved with them that are quite complex. And also, different people are stigmatized essentially in different ways. And in some cases, we assume that people are using substances even when they're not. We assume that people are faking their pain to get substances even when they're not. So this sort of gets at the issue of really trying to unpack our own judgments and our own beliefs about the intersections of things like pain, substance use, and trauma and violence. And again, shifting from a judgmental or, people are making choices sort of mindset to a more compassionate, what would I do if that were me sort of mindset. So maybe, have you think about that a little bit in terms of your own practice and when you see people using different types of substances. So we also are very concerned with, in a TVIC model, ensuring that we're caring for the carers. And this is really, there's two parts to this. The first is what I mentioned right off the top in terms of recognizing when people are struggling with issues like moral distress and even burnout because the work that they're doing is not aligning with the work that they want to do. But also, especially those who are working with groups and individuals who have experienced a lot of trauma, is the idea of secondary traumatic stress or vicarious trauma. And in this case, you're hearing stories of violence. You're working in the elder abuse sector, so you're hearing stories of violence that are really hard to hear. And if you're doing the work every day, you're hearing a lot of those stories. and it's hard not to take those on board. So we need, especially, and as we'll start talking about strategies, we need organizations to recognize the trauma work that their staff are doing and protect and support their workforce. Because if not, then we get also into that cycle of moral distress, moral injury, and burnout. And at this point, I would say one of our biggest societal problems and concerns is that we've got the health and caring professions, workforces burning out and leaving in droves. I work in a school of nursing, and I would say this is one of the major concerns right now, is that we are losing caring professionals at alarming rates, and we really need to address care well-being to be able to protect our workforce. So just like primary experiences of trauma, vicarious trauma and the exposure to other people's trauma leads to anticipatable responses, and these can look just the same as those primary traumatic stresses: fight, flight, freeze, fawn. So being trauma informed basically means recognizing that these forms of traumatic stress are common and they affect how people think, feel, and behave. So we've listed a few examples here. So in terms of thinking, there might be difficulty concentrating or controlling thoughts, or your thoughts are spinning out of control. You might be avoiding certain people, places, or situations because they activate your trauma. You might feel overwhelmed or hypervigilant or distracted, or just tune out, just completely dissociate. So you can imagine if you're in a care encounter with somebody and you're trying to support them, if they seem just completely tuned out, you might find that frustrating as a provider because you're trying to do your job and provide help. So again, switching from frustration to compassion and finding ways to engage that person safely and sort of bring them into the conversation in that moment, or plan for a follow-up when they're in a better place, would be a TBIC approach. And when you hear people talk about their health, things like sleep problems and pain and migraines, et cetera, that can also be a clue that there are trauma experiences that are expressing themselves through poor health and well-being. And again, as I mentioned, behaviors, especially health risk behaviors like substance use and smoking, need to be reframed in terms of people finding ways to cope and get through the day, especially when trauma responses are active. And again, irritability, anger, and so on, and trying to find ways to acknowledge and support those feelings through better interactions, trauma and violence-informed interactions. So I want to just differentiate here, because sometimes at this point when we're doing workshops and I can actually see people's faces, I see concern that people think they have to become trauma experts or experts in cognitive behavioral therapy or specific treatments to be able to do this work. And really, that's not what we're saying here. Trauma-specific services are specialized services, people with specialized skills and training to actually deal directly with the trauma. What we're really talking about is taking that universal approach in all service settings to recognize trauma, and then to tailor our services, whatever service we're providing, in ways that will better support those interactions and allow you to deliver the care in the way that you need to. So trauma-informed care focuses on understanding the impacts of trauma and creating those safe environments for people. I think, as we've done this work for a couple of decades now, the concern for us was that sometimes a trauma-informed approach sort of situates the problem in the minds of individuals. And the idea that we get is, there's something wrong with this person, or I have to make sure not to trigger this person or re-traumatize this person, which we feel is a little bit limiting in terms of understanding the broader array of traumas that people can experience. So this is where we start adding the V, and I usually do this, and I say, there's a big V, and then there's a smaller V, although the smaller V is not very small. So we start by acknowledging that interpersonal forms of violence, as I mentioned before when we talked about the different types of violence, have unique and potentially or devastating impacts on people, or they can have devastating impacts on people, recognizing that many people survive and thrive, and we need to sort of identify how best to support that thriving. But interpersonal forms of violence, including elder abuse and intimate partner violence, are violations of trust. And I think an important point here is, if you have had these experiences, especially if they start in childhood, in terms of neglect and abuse and things like that, or experiencing violence among caregivers in the home, that can have deep impacts on how you attach and form attachments with people. So if it's difficult for you to trust because you have learned through these experiences that trust can be harmful, you might find it difficult to form trusting relationships with care providers in professional contexts or in care-seeking contexts. So we take that into account and realize we might have to work a bit harder as the person providing care to create that trusting relationship and really work on that notion of trust and make sure that the person, that we earn the person's trust by treating them in a respectful way. And as we know, these forms of interpersonal violence are generally chronic and complex. They are ongoing and they can become intergenerational. So when you experience violence in your family of origin as a child, among caregivers in the family, you're more likely to, as an adult, both use and experience violence. So we have to sort of understand those intergenerational patterns of violence. And of course, physical injury and even death is an outcome that we worry about. So our safety is paramount. So it sort of links us back to that idea of being in that activated state and our physiology responding in a way to protect ourselves. And because I'm a gender-based violence researcher, as is Margaret, we always talk about, these experiences as gendered, and that works in multiple ways. So we certainly know that in the context of intimate partner violence, for example, women are more likely to experience IPV and its more serious consequences, but we know also that men experience IPV. However, because of gender norms, it's difficult for men to acknowledge what they're experiencing, and they might not have any help available to them because our society sort of constructs those experiences in certain ways. So there might not be help seeking or even service availability. And when thinking broadly across the gender spectrum, we know that people who don't identify as either men or women experience extraordinarily high forms of intimate partner violence, but there are very few resources available to them, especially as we look at smaller or more isolated jurisdictions. So, we've got gender playing into this in quite problematic ways that also need to be understood. And then we start to look at different groups experiencing, both the social norming, but also violence and its impacts in differential ways, based on race, based on ethnicity, based on newcomer status, based on Indigenous status, and so on. And this is where we start to get into issues of structural violence. The other thing we bring forward, and this is a bit of an evolution that we've tried to make in the concept of TVIC, is understanding that we as individuals also bring, a piece to this, and that is some of these stereotypes or biases that we might have about particular groups. So implicit bias is the term that we use, and based on work by my colleague and friend Judith Sekera. So he's done a lot of research looking at how these attitudes and stereotypes that affect our understanding can impact a care provider interaction with somebody seeking your help. And often we might, have a stereotype of somebody, for example, with a mental health or substance use issue as difficult or unfixable. And if we don't have time to deal with that, especially in this case, this example, it's in emergency departments, we might avoid those patients. And to the patient who's being avoided and ignored, that looks like stigma and discrimination. So even if that's not the place we're necessarily coming from, the fact that we see this person as unfixable or difficult, or the fact that there's a mismatch between what, in this case, emergency departments are actually able to provide, and then, people having to go to EDs because there's nowhere else to go, you've got a provider that's in a situation where they don't want to interact positively with a patient, and a patient who's feeling discriminated against. And many people who have that experience have also had previous bad experiences in healthcare because of these implicit biases. And then that starts to intersect with these other forms of structural violence. So we've listed a few of them here and sort of nodded to them as I've gone along, but certainly racism, sexism, substance use stigma. So, beliefs about whether or not people have choice in using substances and so on. I've talked about resettlement and community integration for newcomers to Canada, colonialism and intergenerational trauma. These are all structural and systemic because they really exist at that broader level. They're the way that we've decided to organize society. And one of the examples I often use is around structural poverty, which is a policy choice. When we decide that, you know, minimum wage legislation puts minimum wage at a rate that is not sustainable in terms of rent and food, and especially now as we see with inflation going up and up, that is a choice that we collectively make in the way that we've structured our society. And it is a choice that is harming people. So that is why we call it structural violence. So this is where the V really starts to come in. And we've sort of conceptualized TVIC as, you know, a critical understanding of interpersonal violence, as I've talked about, and especially that impact on trust and attachment and what that might look like in an interaction. The impacts of structural violence as ongoing in people's lives. So not just what happened in somebody, you know, in somebody's life a long time ago and what's wrong with them now because of that experience, but this ongoing experience of harm because of the way that we've organized society. And then the knowledge of all of this and the interconnectedness of these different forms of trauma, and that, you know, being in one context of trauma might put you at higher risk for other forms of trauma. And there's a bit of complexity there that we have to understand. And then really approaching the work from a perspective of cultural safety and humility, and really, you know, understanding our own power as providers of care and how we can sort of find a way to use that power with instead of power over people, such that we create conditions of safety, such that we can have better care interactions, and therefore better outcomes for people. So moving from trauma-informed to trauma and violence-informed really, as I summarize here, takes into account those broader social conditions and the harms from these inequities, so structural violence, but also the discrimination and harmful practices that are embedded in systems and the way that we do things or the way that we think about things. So that sort of systemic and institutional violence and implicit bias that we might bring. And we all have it. So this is not about shaming and blaming. I think that's the other thing that we need to understand. It's really about self-reflection. It's about conversations. It's about having safe interactions with ourselves and with others to just do a bit better today, tomorrow, and ongoing. And then recognizing ongoing and historical violence, including collective forms of violence. And I do think, COVID has been awful, but it's, I think, brought us to an awareness that we experience these things together, and we need to find ways to thrive out of them together as well. And then the focus on really caring for carers, I think, is an important piece of our TVIC model, that we have to recognize that we need to keep individual providers, but also teams and organizations safe and well. Because if those structures aren't safe and well, how can we be doing our best work with people who need our services? And then this point I made earlier about really thinking about some of these responses to trauma and violence as anticipatable, not as absolutely 100% going to happen, because we have to find, people bring strengths and they find ways to work through the trauma and violence, but to not be surprised when they do happen and to have strategies for supporting people through those experiences. And as I mentioned, we really want to shift the focus from what's wrong with people to what's happened and is still happening in people's lives, and find ways to provide various forms of support. Even if we ourselves can't fix the entire problem right now, because these are big problems, we can have an important impact in the moment by choosing to interact with people in a trauma and violence informed way. And then, especially for this group, I don't have to tell you, but when I speak to other groups, it's really sort of bringing to the fore that these forms of interpersonal violence are particularly pernicious in terms of how people are able to seek care and trust people. So these are the 4 principles of TVIC. As I said, this is not, at this point, it's not incredibly complicated. These are actually fairly simple and translatable principles, but that doesn't mean it's easy to do the work. And what we try to do is really actively focus on structural and systemic forms of violence as particularly harmful and having an impact on how people will interact with you in a care setting. And then really actively countering various forms of discrimination and stigma to promote safety, cultural, physical, and emotional safety for all clients and providers in a care setting. And this is done through fostering opportunities for choice, collaboration, connection, trust, respect, etc., and being strengths-based and capacity building. And now I'm going to let Margaret actually talk about all of those things, and hopefully I'm going to be advancing the slides in the way that she wants me to do.
Thank you, Nadine. Yes, I'm used to advancing my own slides, so this is a stretch for me, but thanks very much. So if you want to go to the next one. I'm going to start with a concept that came from Annalise Trudel, the idea of a choice biography. Nadine was talking a few minutes ago about the way in which we look at people, we think about the choices that they're making. But we each have what she calls these different choice biographies. And so some people have very large biographies by virtue of their social location, their personalities, like the places they live in the world, and their individual circumstances, whereas other people have a smaller choice biography based on all of those intersecting factors. So I'm going to talk about the sort of how the choice biography, how I think about this in terms of helping me live my life, applying the principles that Nadine has been talking about. This is my dad. He's 90, he's going to be 92 this year. And I asked him to, I took a picture of him. I said, I want you to, I'm going to take a picture of you as the Christmas oracle. And so this is my dad, the Christmas oracle. And he enjoys a good laugh about things. And so if we think about the choice biography as it relates to my dad and I, and so Nadine, do you want to advance it? Yep. So there's me. I have lots of choices in the sense that I can drive. I have a job. I have opportunities within my job. I am thinking about where I want to live next. I have an education that affords me lots of choices. And I'm a white woman. I have lived my life as a middle class person. And, these are the things that afford me lots of choices. And then I think about my dad and sort of the way in which his choice biography has become a lot smaller over the last few years. He lost his license. It's a year ago. He can't drive anymore. He needs help with his medications. He is losing his ability to have conversations. And he is much more restricted now in where he is going to live. And he's struggling with all of this, as we all are. And so for me, the question is, how can I support my dad in a way that it's like my job is to do what I can to make his choice biography as big as it can be. And that requires something of me. Do you want to go to the next one? Because it really is my orientation to my father and the choices that are available to him, and my wish to support him and make that choice biography as large as possible. And so it's my orientation to that has to shift. And it's things like slowing down and not bombarding him with options and not, expecting him to make the choices that he might have made 5 years ago. It really is about my orientation to him and understanding that I don't understand the things that go into what makes options for him. So I think that it's important to recognize that in this interdependent, interconnected world, this is a large, this is a shift in the way we see ourselves that I think we still have really not come to grips with. That our systems are still operating in, sort of an industrial age model that thought we were all completely separate and isolated, and what you do, don't affect other people. The truth is that our every action ripples out into the world. We are agents of, our actions make a difference. And so I think that that calls us into a place of thinking about what kind of a difference I want to make on a day-to-day basis, and to understand that my daily choices ripple out in some way that can go toward actually global transformation. If I want the world to be different, then how am I going to be part of it? It is a way to think about myself that, and instead of being a victim of powerful circumstances in the world over which I have no choice, it actually makes me an agent of change where I have chances to make a difference. And so that's the way I'm thinking about the trauma and violence informed principles. If you want to go to the next one. So this picture also, talks about complexity and the need for thinking about things differently. We do need a shift in thinking away from simple models, ways to fix things. And instead, I look at the trauma and violence informed approach as a way to help shift the system, reshape the system in favorable ways, because you are the intervention point, the point of contact. I am the intervention with my dad sometimes, where how I interact with him can make such a difference, to his day. And, I do think it's important. Do you want to go back that one? That last, see, this is the animation part. I know. See, this is why Nadine hates animation. I understand this. But we will have compassion for each other in our struggle too. Yes, that's right. So I do think it's important to note that a lot of times when we're talking about the daily kinds of practices that can make a difference, we forget about the interconnectedness of everything and how these things ripple out into the world. And so the idea of trauma violence informed principles is that if we can make the shift in sort of groups of people, in organizations, in communities, to become trauma and violence informed, we're actually starting to talk about driving large changes that aggregate at a population level. And so you have to see yourself as being part of something that's moving and changing, and having to make decisions on a day-to-day basis about what that's going to look like and what am I going to contribute to the world that I want to live in. I also think this is a survival strategy for all the reasons that Nadine was talking about, in the sense that, people are burned out in the service sector, people are leaving, people have a lot of trauma themselves about feeling like they're part of systems that are not actually helping. And so it is a survival strategy because it asks us to be different in the institutional response that continues to operate as it always has, within sort of an industrial age kind of mindset, I think. So if you want to go to the next slide, I think that this is the TVIC is a radical act in a world that would have us behave like working machines, just moving from one task to the next, moving people along an assembly line of services that are prescribed and in and out the door and off the line as quickly as possible. Taking the time to stop and be present with someone, I think, is a radical intervention in the face of the business as usual world that we are living in. And so all of that just to say, that's the context with which I'm thinking about these principles. I want there to be a revolution, and the revolution is about caring about my every interaction and how I am in it and what I can offer to the situation. It's simple in some ways. It makes the complexity quite thinkable in terms of what can I do to contribute. So I'm going to come back to the principles now that Nadine was talking about, and just think through them a little bit now through that older person lens around how do these principles contribute to supporting services for older people. Nadine talked quite a bit about understanding structural violence and thinking about the ways in which it shows up in our organizations. And so there are things that you can do as a leader in an organization to develop policies and processes that take, into account, the people that you're hiring, the qualities that you're looking for in staff. It can be things like that. You can do training with staff about trauma and violence to acknowledge the mutuality of trauma and violence, the way it moves back and forth, and the way service providers, are themselves impacted by the work that they do. And your services can start from a place of awareness as a foundation for creating that culture of trauma and violence informed care. At an individual level, Nadine's already spoken about looking at challenging behaviors with this sense of understanding that behavior doesn't happen out of a vacuum. There are always reasons for the ways in which people respond to situations, and that it's almost always invisible to us what it is. And so it asks us to not, I'm not saying that we have to, people aren't accountable for their behavior. They are. But I can ask people to be accountable and have compassion for, whatever the circumstances are. So if you go to the next slide. So I was going to talk for a minute from this sort of first principle piece around structural violence and a project that I'm working on with the Canadian Network for the Prevention of Elder Abuse around stopping gender-based violence, specifically in women 55 plus, through promising practices. That's the project. And so one of the things that we want to do is infuse the trauma and violence informed content with a deeper understanding of structural violence as it impacts older women, broadly speaking. You want to go to the next one? So ageism is something, it's the most, tolerated form of discrimination that is so deeply internalized in all of us. Like, how many of you are excited about getting older and can hardly wait for the next birthday? We have internalized these ideas about getting older as being a problem. And for women, the triple threat is being a woman, being an older woman, and being an older woman who's experiencing violence. And then that is compounded by intersecting forms of oppression. I think it was Bridget Penhall who first talked about that triple threat idea. These things pile onto each other. So the idea that domestic violence only affects younger women is a pretty widely held idea still, and it doesn't come from nothing. It comes from the fact that there have been global and national studies done that didn't ask questions of anyone over the age of 49 in terms of their experiences. And so, older women's experience of domestic violence are invisible. Now that's changing, but it is still pretty much like, we're still working with those research studies that did not look at older women. And then there are significant gaps in the research. Like one of the things is when we talk about older people, so you see 55 plus, that's a 40-year age range. Like, my life at 65 is quite different than my mother's, at 80. But we're all kind of lumped together after a certain point that does not, again, see us in sort of the specificities of our lives. That is a kind of, inequity in itself that doesn't take into account the importance of, cohorts. There's three competing research paradigms in social gerontology, geriatrics, and violence against women. Sometimes they have very different ideas about what is, about what things mean and what the research tells us. And what that does is it makes kind of conflicting ideas about research, conflicting ideas about what's happening, and how that translates is kind of a domino effect, in the sense that if there's no research that's widely supported, things don't get funded. Do you want to go to the next slide? So, oh, you're going backwards. Yes, okay, thank you, that's perfect. So that's that domino effect, right? That if there's no research that supports the need, then there's no services. And isn't that what we understand when we're talking about elder abuse, older women and men, and the lack of services for them? So, these things all have a reason. Go ahead. And then there are sector differences in which, you know, the healthcare sector in particular, you can go to the next one, Nadine, you know, hasn't considered violence as a health issue. And so it can sit apart from the traditional scope of healthcare policy, education, and services. The VAW sector, until recently, really weren't thinking about older women and what they might need in the context of violence against women's services. Go ahead. And go ahead, one more, because it's animation. Yes, there. And then, you know, people sort of things that people are experiencing when they're talking about it can be written off as, you know, just getting older. These are, oh yes, these are the things that happen to older people, without actually leaning in to ask questions and have the conversation. So health professionals working most closely with seniors. Now, I do think this is changing, but they have not traditionally been trained to recognize warning signs and risk factors of domestic violence. So you can see these are one of the places that we need to be working at a system level, but that the impacts are quite individual. If, you know, if people aren't comfortable having conversations about violence in relationships, and yet there are warning signs that present themselves and you don't know what to do with them, it really presents, you know, a missed opportunity in terms of connecting with a woman who's experiencing violence. Go ahead. So what we have is many older women too have internalized all these things, right? They're surprised to think that their experiences are abnormal or worthy of any special services. This is just about life. And so that internalization means that, you know, reporting is infrequent and difficult for people to, you know, reach out and ask for help. And so I come back to, can you back up one? I think this is such a powerful quote. This is also Teresa Zink said this, you know, as women age, their horizons for action diminish and they see themselves as having fewer life choices within the scope of decreasing power. This is a pretty sad statement for all of us, and, you know, asking us to do something. So if you want to go to the it's the animation, come back to thinking about that choice biography. And then go one more, Nadine, you see all these things that come into play, click it again, that, you know, go into an individual's choices, and that idea of narrowing as you get older, and the importance of people who are supporting older women, older people in general, to have a sense about all these contributing factors that are stripped away as you get older that make that choice biography more and more narrow. How does it change your orientation if you think about wanting to expand that choice biography for her, you know, in whatever way you can? You really do need to understand that first principle and all of these elements that contribute to her situation. Go ahead. So, you know, the second principle is about creating emotionally and physically safe, culturally safe environments. And so there are great ideas about how you can do that at an organizational level and also at an individual level. If you want to go to the next one. You know, I kind of boil it down to this idea of cultural safety and respectful engagement that recognizes and strives to address those power imbalances that are always in the service system, in relationships. I can do that by saying, what is the impact that I'm having in this moment? What is the impact of my organization? How do I use my power to create safety? These are, as I said, these are deeply personal ways of interacting with people and the system. Go to the next one. And so then the third principle around fostering opportunities for choice, collaboration, and connection. Let's talk about fostering meaningful opportunities for choices, right? So again, at an organizational level, you can look at policies and processes. And then as an individual, you have to think about, you know, not imposing your idea about what needs to happen, you know, thinking about that choice biography of the other person. Go to the next one. So again, the choice biography, not so much what I think is best, but what is the practice? It has to be one of cultural humility where I don't think I know what is best. I have to ask questions. And then I use my power to find flex in the system, you know, to do the workarounds, to find ways to make things work for people in small and large ways. Go ahead. And then, of course, using a strengths-based and capacity building approach, thinking about it from an organizational lens and also as a provider. What are the kinds of things like, so you can see there, it's about taking that time. It actually is important to be able to do that. And thinking about, what do I need to do to be able to actually be present with someone? This is not a small task, because we are endlessly distracted and pushed to meet deadlines and deliverables and, schedules. Go ahead. So, the radical act is about taking time and slowing down with older people in particular, but really with anyone, to take the time to connect. Every single encounter is an intervention. And so thinking about the quality of that intervention, taking responsibility for that, and using my perspective to reflect back to you what I see, these are powerful moments with people that can really make a difference, that's meaningful, that makes me feel like what I'm doing actually does make a difference, which I think is so important right now. Go ahead. So change is possible. I think we need to be optimistic. Things seem dark right now, but things need to change. And so being part of the change is a way to wake up in the morning and feel like I have something to contribute that's important. Go ahead. So Nadine's going to pick up from here.
I think it's back to me. Thanks, Margaret. I'm always so inspired when I hear you speak about this stuff and really articulate it in such meaningful and personal ways. So thank you for that. I did just want to put this slide in, because in some of our work, we've done a lot of work on the TBIC concept, and I'll show you some of our resources. But really, much of this grew out of a research and implementation program called Equip Healthcare. So you see the URL there. And we position trauma and violence-informed care as one of the 3 key dimensions of what we call equity-oriented care, or equity-promoting services. And we've talked a bit about, cultural safety and anti-racism, and creating a culture where everyone feels safe, regardless of, how they identify in other ways. And also that notion about really focusing on ways to reduce harm by looking at stigma, especially substance use stigma. And we're really trying to reframe towards the idea of substance use health. And I mention this because some of the research that we've done through Equip and through this sort of model of equity-oriented care with this TBIC component does show what Margaret just said, which is this can make a difference. So when you provide care using this model in this equity-oriented way, and we've done longitudinal analysis in a number of primary care sites, for example, and then more recently with emergency departments, you can shift important outcomes. So when people are provided care in equity-oriented, trauma and violence, culturally safe ways, they are more likely to feel that they have mastery and control over their healthcare, that they do have those choices, and that they can have a better path to improved health outcomes. And they know that people are caring about them in ways that align with their priorities and needs. So we do have data and published papers showing that you can reduce depressive symptoms, you can reduce PTSD symptoms, you can even reduce chronic disabling pain, which is a really difficult outcome to reduce when you provide care in equity-oriented ways, and improve people's well-being. So that's a really important thing. And given the complexity of care environments and people's lives and the interaction and relational nature of these services, it was pretty cool to actually show that. And in our emergency department study, we actually showed that providing equity-oriented care in the emergency department that took up the model the most fulsomely, they actually reduced an important administrative metric, which is people leaving without their care complete. So when people felt they were being treated with compassion, respect, and in these equity-promoting ways, they didn't leave before they got care. And of course, if you leave before you get care, you're not going to have improved outcomes. So that's a really important piece as well. So I did just want to mention that, and then tell you there are tons of resources here if you want to take this broader equity-oriented approach, and each of our key dimensions has tools attached to it. So I wanted just to have a few things. We've got about 15 minutes left, so I'll take 5 more minutes or so, and then leave about 10 minutes for questions. But people at this point usually say, okay, well, how do I start? How do I be that intervention? How do I, be an agent of change, as Margaret has just talked about? And I think it does start with how we think about things and how we think about the people, who we're serving, who we're there to actually provide care for. So shifting from sort of non-TBIC thinking, or what my good friend and colleague Vicky Smyth would call stinking thinking, to a TBIC way of thinking is an important first step. So instead of thinking about somebody as weak or as an addict or a junkie, you're thinking, you know what? Wow, he's strong for surviving what he's survived. They need our help. They're a survivor, not a victim. So the way that we think about people, and then the way that we talk about people, which I think is my next slide, is actually very important, both in how we talk with those we're serving, but also how we talk about people with our colleagues, and importantly, in documentation. So if you're in charge of charting interactions, you have to remember that what you put into a chart follows that person. That label can follow that person from one encounter to the next. And I've had close colleagues, especially those who work in outreach services, say, when I see the words drug seeking in a chart, it absolutely, that person has had terrible experiences from one service to another, because that label just follows them. It's not, instead of acknowledging that they might be using substances for pain related to trauma, unresolved trauma, they're seen as drug seeking. So using language and being person first and optimistic in the way that we use language, respecting people's autonomy and recognizing that they're an expert in their life. So instead of saying they're non-compliant or unmotivated, you say, you know what, they chose something else. That's, their path is not the same as what I thought it should be, but they're choosing to do things in a way that makes sense to them. And again, the idea of normalizing that these responses to trauma, instead of a toughen up sort of mentality, it's trauma has these effects, and we want to support people in coping and adapting and having survival skills. And the idea that things can change. So when we say survivor, we're saying somebody who has lived through and is continuing. Victim really seems very sort of negative, and it stops people. It sort of freezes people in that moment. So the use of language is very important. That is certainly something that we can do on a day-to-day basis and be mindful of. And I always say to people, especially administrators at this point, it does not cost any more money to use respectful, person first, language that supports people in their journeys. Then sort of a next level thing that we suggest when people in organizations are wanting to take up TBIC is what we call a trauma review exercise or an equity walkthrough. These are similar sorts of tools that we've created to get you started thinking about what it's like to be in your space, or what it's like to be a provider that works in someone else's space. So as a home visitor, for example, or somebody who does community outreach, and really sort of thinking through, and we have a picture of a shoe here because it's really walking in somebody's shoes. What's it like to visit the clinic or the service center or the group, session that you're holding for seniors? So let's think that through and make sure that everybody feels welcome, especially by recognizing who might not feel welcome, and really then talking to people who use your service to discern what can be done to make everyone feel more welcome. So these are a couple of tools that we've developed on the Equip site. The Equity Walkthrough has an explainer video and is also available in French. And then we always advocate, again, as Margaret walked us through, there's the organizational level responsibility to becoming trauma and violence informed, and the individual. I always like to prioritize the organizational, because my concern is always that as individuals, if we've convinced you today to change your practice, but your organization doesn't support that or keeps in place policies that actively counter your ability to work in these new ways, that might actually increase the feelings of moral distress, because now you see what you want to be doing and are still unable to do it. So we really want to promote organizations taking responsibility for things, especially like staff well-being, understanding vicarious trauma, providing things like reflective supervision and staff-initiated debriefing and employee assistance programs. Self-care is important, but we always stay away from assuming that we just tell people to care for themselves, because we don't think that really reflects the organization's responsibility to caring for its workforce. And then we've created lots of online learning. As I've mentioned, we've done many of these workshops in many different contexts. So if you were intrigued by what you heard today, I would certainly encourage you to go to equiphealthcare.ca, online courses. This is our foundations curriculum, which is about 6 to 8 hours, depending on how deeply you engage with the material. It's free. You just follow the link above, and you can register on a learning management system at University of British Columbia, and you can start, stop, come back to where you were. There's a downloadable notebook, and it really sort of takes you through the content that we've very briefly touched on today in much more detail. And some of the beautiful illustrations that you've seen are actually from the curriculum, the ones that we have in our slides. And we have a companion module for those doing home visits in the context of public health. We're developing one right now for primary care and lung cancer screening, and there are a couple of others in the works as well. So these are tools that we're continually evolving to support practice in different sectors. And then there's our forthcoming handbook. Margaret actually was lead author on 2 of the chapters, and I was just doing page proofs this morning, Margaret. And actually one of the chapters that she and I wrote together was one of the favorites of our peer reviewers. So I highly recommend this handbook, which should be coming out in the next few months. And once we have the online link, certainly share it with Rayanne, who can hopefully share that with folks. So that is what we had today. We've got about 10 minutes for questions. That's our contact information. And I will leave that up for another few seconds, Rayanne, if you want to take over the moderation, or I'm not sure what you plan to do.
Great. Thank you both for a great and informative presentation today. I know I've learned some new concepts and the dynamics. It's we get a little bit of understanding, but it's sort of opened my eyes to a lot of I know the things that Margaret's been talking about for many meetings that we've had, so it kind of gives me a better understanding of that. There was one question that I actually wrote down almost just the same time the person wrote it in the question box was, you talked at the end there about shifting, sort of those power dynamics and changing the organizations. We want to incorporate this approach, and yet we're driven by the data and the outcomes from agencies to say, okay, I checked off the box. This is what we wanted to achieve this year. So many people got this referral, et cetera, whatever they're measuring. But how do we switch that, or what's your suggestions on moving that needle to agencies, shifting those outcome deliverables to reflect the need of seniors that we're serving, so we're not just sort of in that mode in the work that we're trying to achieve.
Margaret, do you want me to have a go, or
You go, and then I'll go.
Okay, I can't speak specifically to the context of abuse of older adults, but I do know that, yeah, and I saw that the question in the box. That's why we do the research. So I did mention briefly that in our equip healthcare work, we are selecting outcomes that are important to health policy folks, but also like hospital administrators, primary care clinic managers, and so on. So when, I say something like we were able to reduce the rates at which people left without their care complete, to many of us out in the public, that might not seem like a lot, but to a hospital administrator, that's actually a pretty important thing, because that's something they have to report on. So what we do, and through the equip suite of resources, we have what's called the Equity Action Kit. And it's actually sort of an implementation science model. I didn't have enough time to show it today, but it's all freely available. And what we're trying to do is support organizations to pick the metrics that are important to them, the ones that are going to convince policymakers, but also the ones that are going to convince the direct service staff, right? The things that you can see make a difference in your work. And then embed those metrics into the continuous quality improvement, or whatever sort of name you have for that process of transforming and then sustaining those positive changes to reflect equity and to reflect better care for people. So we align, when we're talking to healthcare audiences, equity-oriented care with the quadruple aim of health system improvement, and that's something that policy folks, that makes sense to them. Right. So there is that sort of strategic approach as well to make sure that we're not just researchers, saying researchy things off in the ether that make no sense to people in the real world, that these are things that are important. What we're finding now is the burnout that staff are feeling is of serious concern to leaders, and they want ways to, basically retain their workforce and keep them healthy. But also there have been so many horrific stories of things like, the Joyce Echequan case in Quebec, where people are literally being killed by racism. So we've had, hospitals and other organizations come and say, we need to do something about, with an anti-Indigenous racism lens, like we need to address this. So there are things that are driving people to us now, actually, because they know things need to change. So Margaret, did you want to?
It's such a big question. I'm just gonna say that I do think we're living in an important time of collapsing systems. They are unsustainable. And so engaging leaders who see the value of doing exactly what Nadine is talking about. This is in all of our interests. And so we need to find a way to identify those outcomes that can speak to policymakers. But it is in the work of working together across disciplines and sectors that I think the real, one of the other values of the trauma violence informed principles and implementing them, driving them into our organizations and our practices, has also the effect of building bridges across siloed sectors to work together more collaboratively. The more we do that, the better we're able to speak truth to power, if you will, and to make the case for investing actually in prevention. Like our entire service system is crisis oriented. We wait for the crisis. That is the most expensive response possible, not just in terms of the economics of it, but in life costs. And so this is a big case that we need to be able to make together. So a lot of this is about how do we talk about change? What's the narrative? So I'm talking very clearly around trauma and violence informed care is a survival strategy. It is a way for us to survive what we're in right now, because it speaks to the immediacy of caring about people. And that can happen anywhere at any time, even in oppressive. Like that is how do we protect that autonomy? And so those are the conversations. And I think that we buttress that with the research, but the work is on the ground. It really is, it's the work happens, it's the people who are standing closest to the fire doing the work.
Yeah,
That's where the change is happening.
Yeah, and that kind of ties into the question that was just posted around how, as educators or doing training with a lot of these agencies are providing services to seniors, and many of the capacities and colleagues online today is, how do we get them to understand that value? And I think you just touched on some of those key points, and maybe we can highlight some of those in our when we post this after on our website too, because that's what I was, kind of thinking about. How do we implement that sort of change? And to your point too, around, we are in that responsive crisis mode, right? Which bring me back to some of the work that we've collaborated on. The It's Not Right is that how can we shift that change to the community to inform family members to think about this approach, the trauma and violence informed approach, to look about the choices of, like you were talking about your father, how do we engage that education to the family and community members, to not only the providers that we've focused on today, but also community. So I don't know if you have any comments on that.
Lots, but we have 3 minutes.
I know.
But I do think you're absolutely right. And one of the really productive spaces about working in the elder abuse field is working with the people causing the harm and extending trauma and violence informed thinking in that direction. That's still pretty radical, because we want to write them off as bad people who need to be punished and vote them off the planet. Well, like that is ridiculous. So we have to find a way. And that's actually what older people want, is they want their children, their grandchildren, to get the help they need. So there's a rethinking at that level, talking about outcomes, keeping people out of the justice system, keeping people out of crisis. That is the way where we put our attention. So things like applying these principles on a day-to-day basis, I think, is an active strategy that can happen anywhere, anytime. And that's where, you get that multiplier effect. If we can think of ourselves in little clusters, if we're all practicing the principles and talking about them, because we're connected to the larger system, it will have an impact. Mm-hmm. So clarifying our messages, being able to speak simply about what this means, giving people actions that make sense, that actually come down to a day-to-day practice, that's where we need to go.
Yeah, I agree. And there was just one comment here about, having coworkers who just don't understand that older adults have experienced trauma. And I think we talk a lot it's a societal, maybe it's an ageism thing as well, which, you know, I wrote down here as well, as we, you know, seniors have gone through a lot of trauma over their years. They've had a longer life, you know, experiences, and, you know, taking the time to like, let's go through that biography as you were talking about, to figure out what are those triggers. We can't ignore them. But sometimes people are afraid to even ask, right? Do they want to know? But it's taking that time. And I think, you know, as we wind down, I think, you know, the message that I might just have your last word, but that time is so precious, and how we can maximize that to ask some of these key questions, because choices do change. Life transitions change. Your choices change. Whether you move into retirement home, your choices do change, but maybe there's other new choices, right? You get a lot of choice that taken away,
Yes.
but there's opportunities for other new choices. And I think we don't think that. We always think the negative, what's taken away, but there's maybe new opportunities for people. So any last words before we wrap up?
Well, I was just going to say thanks, Rand, for even mentioning that, the new choices and trying to find the positive, because you get into the language of trauma, violence, and it does feel very heavy. And I mentioned before the idea of structural resilience and also vicarious resilience, but really trying to not put it all on individuals and thinking about how we learn from how people survive and thrive, and take joy in that, that people do that, and how we bring that into our own lives, I think is hugely important. And I personally also want to thank Jamie, Mike, and Kelly for their extraordinary work. And I apologize for how quickly I speak, but thank you for your work interpreting. Margaret?
Yeah, I wanted to, I think this is a larger conversation that needs to be ongoing. So thank you very much for asking us. And again, thank you to the interpreters and to Rayanne for inviting us. This is the first time Rayanne or Nadine and I have done this presentation together, and I love working with Nadine. So thank you.
Yeah, and I'm
Well,
sorry
thank you
about the
both.
slides.
Hopefully there'll be more opportunity for us to collaborate in the future for maybe future sessions or training. So thank you all. And we just have a 5-minute break, and we will join our last keynote presentation at 3:30 or 2:35. Sorry. All right. Thank you both.
Thank you.
And we will engage with our back on feed loop. Thank you very much.
Thanks, everyone.